through scenarios where you saw people going through scenarios, getting trained, and somebody coming and giving you feedback. I just want to go over a little bit more and show you how simulation can maybe make it very even for all trainees across all centers. I want to acknowledge that I'm one of the directors of TAC, and I have 3 of my colleagues / teachers' name who have been gracious enough to give me their data to use to kind of drive the philosophy of simulation education across. So I'm grateful to all of them. I'm going to quickly talk on these 3 headings. One, what are the common challenges faced in adult learning pertaining to medical education in our country, and how simulation can be one of the solutions. It's not the only solution in trying to standardize training, evaluation, and feedback, and we'll try to conclude with those kinds of thoughts. Okay. First question is, what do we teach adults, especially doctors? Dr. Saibun already talked about the 3 main domains of clinical education. One is the cognitive domain, where we talk about the knowledge. Next is the affective domain, where we teach them the attitude in terms of how they judge, what they need to do, and modify their behaviors. And the last is psychomotor domain, which is basically technical skills. How do you intubate? How do you put a central line? How do you put a chest tube? Most educators in this room will agree the easiest to teach is a psychomotor skill. Now you can take somebody, put them to 2-3 hours of training either in real life practice or in a simulator where to teach them how to do a particular skill. I think they can learn that skill very, very easily. The next domain probably easy to teach would be the cognitive skill. Probably the knowledge will take a little bit more time to impart, but probably it can be done reasonably well. But the toughest domain for any teacher is to change the behavior of your trainee or behavior of your staff. It takes a long time, and it is resistant for various factors to change, and therefore that is a very difficult domain to teach in real life across all centers. Second, how we teach. How do we teach? And I was inspired by one of my teachers who always said that if the learner did not learn, the teacher did not teach. Meaning whatever I do today or whatever I did today to teach my trainee, if they did not learn what I wanted them to learn, that means I have failed in my way of teaching. I need to modify my style and maybe do it in a way that is more easier and friendlier for them. For this, there could be several reasons. The teacher alone may not be the only person to be blamed. It could be the learner-centric issues where the learner dose, what I call dose is the number of hours of teaching he probably needs would vary from individual to individual. Some people may have a very fast grasp. Some people may need repetitions of 10 times or 15 times before they get the grasp. So dose of teaching that I need to do to impart knowledge may be different. The duration and the domain I'm going to affect, again, like I told you, the 3 domains will change depending on what I'm going to do. To change behavior, I have to do this over and over and over again over a period of time before I will change behavior, versus for skill, I can do it in one session. Second, there could be teacher-centric issues. First of all, what kind of expertise do you have? In my group, in intensive care, I am an internist. My ability to handle a difficult airway will be definitely far inferior to an anesthetist who's one of my colleagues. So if I'm going to be teaching difficult airway, then I probably don't have as much expertise as my other colleague who's probably more proficient. On the other hand, if I'm going to teach acid-base and complex physiology, then I'm probably better off than my anesthetist colleague, and vice versa. So we all complement each other in real life when we work as a team, but in education, expertise can vary. Second, even if I'm an expert in a particular field, my proficiency to teach can vary. So not all good doctors are good teachers, and not all good teachers are good doctors. So it's vice versa. We have seen examples of both happening in real life all across. Therefore, a trainee can be variably exposed to different teachers with different expertise and different proficiency. And finally, the lack of time for all of us to completely seclude so that we can go away and just do a half-a-day teaching session without being bothered by our clinical responsibilities almost rarely happens in Indian setting or anywhere else in the world. So the true challenge for all teachers is that I want to ensure competency of all my trainees across all the domains. Ideally, when they go through a 2-year or a 3-year fellowship or a training program, I need to make sure they are proficient in their cognitive domain, psychomotor domain, and affective domain. I need to make sure that all of them get the same degree of exposure and training before they finish the training. And how is it just possible to do this kind of a standardization in a real life? So in India, there are also other challenges that we face with. We have government setups and corporate setups and somewhere in between that differ in terms of the patient load, patient volume, patient variety that come. Depends on the wide variety of teachers. You can argue that the patients and teachers can be spread equally across both the corporate setups and government setups, but the resources available to teach may vary between a corporate setup and a government setup. even when the resources are available in a corporate setup, you may not be able to teach well because it's your private patients and you're worried about patient safety, patient quality, medical legal issues, that we may not be able to do justice to our education purely in a private setup, even with all the infrastructures. Second, I need to make sure that my trainee is very comfortable intubating. So ideally, I should allow him to intubate as many times as he wants till he secures an airway. On the other hand, I have an obligation to the patient to say I need to make it as safe as possible. So most people would say the most experienced person should be handling the airway, in which case my novice trainee will never get into a position where he can become an expert. And there are hospital policies in place, ideally for good measure, where they are placed for patient safety, which can actually be a barrier to education. For example, in one of the places where we train, anytime there is a cardiac arrest, an ACLS team, which is critical care team, would go to the scene. They would handle the crisis scenario, triage the patient to the ICU, step down, or keep the patient in the ward. And this happened on a consistent basis 24/7, that all medical residents, even after doing 3 years of medical residency or post-graduation, were not comfortable doing an ACLS code alone. So kind of, no, for a patient safety reason, we did this, and then it kind of hindered their education. Where I trained, all the patients in the ICU had to be intubated by anesthetists during my residency. So during my entire 3 years of my MD General Medicine, I went through without intubating because we had to call by hospital policy an anesthetist who's on call to come and intubate. So what is done for patient safety may be a hindrance to effective training across centers. How can somebody who's new become an expert in any particular area? And the only thing that has been shown is deliberate practice. And, knowingly or unknowingly, people like Tendulkar and Roger Federer have said the same thing in different interviews. Like Andre Agassi used to say that he used to hit 10,000 forehands a day and 10,000 backhands a day, which is nothing but deliberate practice. They practice it day in and day out. So they become an expert when they actually are doing a particular skill. And deliberate practice has 3 particular components. First component is you have to practice with a specific goal. You cannot say, I'm just going to go and intubate today. Your goal has to be, I want to make sure I get all the equipments ready. I need to know how to assess an airway. I need to have all the equipments ready for intubation. I need to know how to use a laryngoscope. I need to know how to use a bougie. I need to know how to look at my cords. I need to know how to look at the tube going through the cords. So you have to have specific goals rather than saying, I'm going to go and intubate the next 10 people in my ICU. That will not help you if your process of intubating is not being monitored and feedback provided. Second, you need to have immediate feedback. Somebody has to be watching you when you're doing it and has to tell you that your technique is wrong, maybe you should try this, maybe you're too aggressive, maybe a laryngoscope is too superficial. Whatever it is, they need to give you feedback. And the last criteria is that you have to give equal importance to the process and the outcome. Just because you successfully intubate doesn't make yourself an expert. You need to know exactly if you followed each one of the steps that are necessary for that intubation and you're still successful. So the importance has to be given both to the process and the outcome. Only if all these criteria are met, you call it deliberate practice. Unless you have this deliberate practice, it is difficult to become an expert in whatever field you choose to do. So, can we do it with the existing tools that we have, regularly training people? We have mannequins. Mannequins are static. We talked about skill training. I can just use a mannequin to intubate, put a line, put a chest tube, but I cannot make it change the anatomy, making it more difficult or more easy for my trainee to do. I can do only skills training. I cannot do cognitive training, or I cannot do affective domain training through that. Animal models are expensive. It does not allow for repetition. I can buy one pig and do a cricothoracotomy, but that's it. It's gone. I cannot buy 100 pigs to do 100 cricothoracotomies for all my trainees. Again, becomes very, very difficult. Standardized patients are very, very expensive when we have them in the Western world. And you cannot teach technical skills on standard patients. You cannot teach cognitive skills. You cannot teach leadership skills. You can only teach communication skills and maybe basic physical examination skills that are required at a medical school level. What about clinical experience? All of us in this room would say, we didn't have this technology before. We have all turned out to be fine doctors. Purely based on clinical experience, is it good enough? The answer is yes, it is good enough, but probably not enough for us to achieve what we want to do. First of all, we would get a variable exposure to patients, variable exposure to devices, and variable exposure to teachers. Now, I went through a fellowship training where we did a lot of liver transplant, and hence, even then, after 6 months of training, I never saw a patient where I need to put a Sensitake and Blackmore tube. Every time a patient would come with a massive GI bleed, I would be in my night call or it would be a night off or something else would happen that I never learned to put a sense-taken Blackmore tube despite working in a very, very busy liver ICU. And even when I get an opportunity to do that, I may have the device, but I may not have anybody to supervise me, and a nurse or a senior colleague is the guy who's going to be teaching me how to go about doing it. Variable feedback. Even if there is a teacher present, your ability to give feedback to the trainees is again variable. Some people can be exceptionally brutally harsh. Some people can be very, very mild so that they don't want you to make you feel bad. But it has to be a right balance of trying to tell you all the good things you have done and maybe the things you should do differently. And that is a fine art which cannot be generalized across all the teachers. And again, depending on who's the teacher, what time of the day it's happening. If it's happening at 2 in the morning, then I may not get any feedback. If it's happening at 2 in the afternoon, I will get very good feedback from my trainee. It does not allow for deliberate practice purely because the particular event is very rare. For example, I see 2 difficult airways a year. How am I going to practice difficult airway management on a consistent basis and still be able to learn all this? Lack of resources. Maybe my new modified video laryngoscope doesn't work today when I need it the most. The bulb is gone, the camera is gone, something it has gone to the biomedical department. It may not be available. Variability in feedback we talked about. And finally, patient safety concerns. It doesn't allow me for practice. If I don't get my intubation in the first 1 attempt or second attempt, my consultant or my senior colleague is going to take over for rightly so, for the patient's benefit and try to go ahead and do the intubation where I have lost valuable practice of trying to get the endotracheal tube back in. Last and most importantly, the single most thing that probably will change your behavior is if you know you've taken a bad decision, to see what is the consequence of the bad decision will probably be a lot more educative to modify your behavior than anything else. I can stand here and say, you have to follow the algorithm. If you do not follow the algorithm, you're going to miss so many things. You probably will listen to this here, it will get out of there. But when you actually do it, you do not follow the algorithm and you find a problem, then it will probably stay in your mind long enough and that will alter your behavior. So to change your affective domain, you need to be able to witness the consequences of bad decisions. And that does not happen in real life because we do not allow that to happen purely for patient safety reasons. So why use simulation for all that? Educational reasons, we already talked about standardization. I can take the same mannequin across different institutions, use the same scenarios with the same checklist and say, these are all the specific tasks I want you to be proficient with. It is learner-centered. I can just say the simulation is there. I have pre-programmed the scenario. Whenever you have free time, you can just go and practice this particular scenario and gain skill. You can train a few technicians who can be available round the clock, who can educate your trainees and see if your technique is modified. It facilitates a wide variety of techniques. So you will see that we can use difficult airway, we can use a defibrillator, I can do a cricothoracotomy, I can put a chest tube, I can run trauma scenarios, do log rolling, fix the neck, I can do a whole bunch of stuff with the simulator. It is dynamic, so it allows for problem solving exercises. So if you get into this problem, what is the next step in your algorithm? It makes it more cognitively challenging for you to be able to comfortably do it. It's easy to operate. I can take any one of you in this room and maybe put you to a 2 to 3 hour behind the scene, how to run a simulator, and all of you can comfortably do it. Easily transportable, as you can see. And finally, it allows for deliberate practice, which is the single most factor that is going to make you an expert if you're a novice. So now I want to just show a few studies that we have done differently and just show you the value of simulation in trying to standardize all this. This is a small study where we essentially looked at fellows who wanted to do difficult airway management, and we said that we will put them through specific scenarios and see how they perform in those scenarios. And what we did is, we gave them baseline training. Sorry about this remote. We gave them pre-test, then we actually intervened with the simulation training, and then we gave a post-test. Very simple. We just wanted to know how they did before, how they did after, put them to a structured training. And I want to address certain important educational concepts here. And the reason for baseline training would be, I want to get their baseline perception and their baseline deficits. How much are they aware about what they know and what their deficits are? And that is going to be an affective problem or an attitude problem. If they think they know everything, but they're not able to perform, then that clearly tells me that they have a perception problem. We had a pre-test web learning module, which ensures that the basic knowledge base was standardized. Then we had a short lecture on principles of DAM, reinforcing the basic knowledge. Then we gave a skill stations, which is half a day, only hands-on training on various airway devices, which allows for deliberate practice. You can do it over and over and again till your technique of inserting a laryngeal mask airway is perfected. And testing scenarios with specific criteria for pass and fail, I will show you, and giving them standardized evaluation and feedback is what we did. And the feedback was standardized using video recordings and checklists. All of you would have seen the feedback for now, but if you look at the evaluation part, we divided into various domains, all the 3 domains that we had talked about. Psychomotor domain, something simple like did not perform adequate bag mask ventilation. We had a predefined criteria to say if they do not do this, then it means that they have not done a good job of bag mask ventilation. Poor technique of any of the devices. It doesn't matter if your LMA is inserted or not. If you have not inserted in the right way, then you're still considered a failure. Cognitive domain did not assess airway, wrong choice of technique based on the algorithm, did not follow the algorithm. Affective domain did not call for help. They thought they could handle the airway when things were going very, very wrongly. Did not follow the algorithm, again telling you that you can jump steps. You think that you know a lot more, you're more confident, maybe even overconfident, that tells you. Then assessment of efficiency in the tested task, whether you're able to obtain the airway in an allotted time or not. So the evaluation is done based on these criteria, and the trainees were said whether they passed or failed based on these objective criteria. And feedback was done like we did today. We have an objective checklist of things that have happened with a video of how they are performing and what the monitor was showing at that time. This is very, very helpful if you think of it. There is 2 things that people need to understand. One is about constructive criticism, other is reflective learning. Reflective learning helps you by watching yourself do a mistake. You will alter your behavior more likely than somebody telling you to alter your behavior. And that simulation helps you to alter the affective domain much more interestingly. What we found is their confidence, competence went very well across all the devices that we taught them. And what we found in this study is that it is a good way to standardize training. We guaranteed a knowledge base. We were able to show them different skills. We gave them more time to practice and perfect. There was no pressure about your trainees for following you. There is no embarrassment. You got immediate feedback every time you got it. So we met criteria for deliberate practice. We standardize evaluation across all 3 domains, which is very difficult to do in real life, using the same objective criteria. Standardize the feedback based on the checklist that we have used as you have seen before. And the bonus is we could record every single trainee interaction digitally, like what we did today, and save it in a folder where when we get an accreditation, like when the national board comes for accreditation, we can open the folder and say this trainee has gone through all this training. So we have proof of training. Therefore, it's easy for our recognition to have continued exposure and accreditation. And patient safety was never compromised during all this. Next, in this scenario, what we did is we took a whole bunch of people and did team training. As you know, for an ACLS, we have airway people, we have people who do drug cards, the team leader is standing there. We define specific roles for each person, that this is what they are supposed to do. And essentially, we put them through a scenario and actually did a yes or no. Within 60 seconds, they have to come identify themselves, check the airway, open the airway, check breathing, and assess ventilation. All this is something very simple in a code scenario that every single person is supposed to do. So we basically went and said yes or no, whether they actually performed the checklist or not, objectively. And what we did is, at the end of the scenario, we went and asked them, how did you think you did? And the circle is the self. Everybody thought they did a very, very good job. This is the peers. How did you think your team did? They also thought they did very, very well. But when we actually used the checklist and saw how many of the items they had actually done, they'd actually done a very, very poor job. They didn't even know that they were doing a poor job. And this is what we call unconsciously incompetent. You don't even know what mistakes you're doing, so you're not going to alter your behavior based on that. And as you can see, as the number of sessions, you could see session 1, session 2, session 3, session 4. As you keep doing this over and over again, they come to the point where not only that they are confident about it, they are also doing it rightly, even if I objectively measure. Again, this is a classic example of how I can alter the affective domain rather than just the cognitive or the technical domain alone that I can do. So it's a very useful educational tool for standardizing training for even difficult to teach areas such as teamwork. You can never teach teamwork in a single, you cannot take one person and say, I will teach you teamwork. It is just not possible. And Dr. Saibun said, I can get different people from different areas, a nurse, physiotherapist, medical student, resident, a critical care fellow, a cardiologist, all of them into one team and teach them how to work as a team. And it provides insight into the learner on deficits, and it helps me modulate and monitor their behavior and their change in behavior over time. And this is the last study I'm going to show you. It's a very simple study. What we did is we took the medical students who rotate through the ICU. On the first 2 days of the rotation and the last 2 days of the rotation, we gave them a written exam, MCQ exam, 100 questions, 50 questions, and said how they fare before and after. We did OSCE, which is Objective Structural Clinical Examination, where we give specific stations. We give them a particular ECG and ask 3 questions relating to the ECG or show an X-ray and ask a couple of questions. They go through 2 or 3 stations, even up to 10 stations, and then we score them based on that. Finally, we gave them a simulation scenario, couple of scenarios before and couple of scenarios after. What we found was very interesting. Everybody was very good in theory even before. They had a bigger delta. OSCE also had a bigger delta, but you can see that the delta is the smallest in simulation. Why? Because you know, you have the knowledge, you have the understanding, but you're not able to apply. Application takes a lot more time than the knowledge and the other things. So which is pretty much what we showed, that with simulation, it clearly shows that it's a much better way to evaluate somebody's overall application at the bedside rather than just an MCQ exam or an OSCE exam. And I just want to show you why this is useful. Something called Bloom's taxonomy. Within the cognitive domain, there are so many things that people can look at: knowledge, comprehension, application, analysis, synthesis, and evaluation. Now in the newer version, they just say it simply: remembering, understanding, applying, analyzing, evaluating, and creating. So most of us are here. Remembering, understanding, we have a good way of testing. We have examinations there we can test. Applying, maybe a little. When it comes to evaluating, synthesizing, analyzing, and creating, there is no tool right now available. The best we have is the clinical examination when we do, and they're so nervous at that particular point. We don't have an objective checklist. If you miss a murmur, you die. If you miss the hepatomegaly, you essentially get failed. So there is no objective criteria of how all these things are done. And I would argue that written exams are at the bottom of the pyramid. OSCE is in the middle of the pyramid. Simulation can help you evaluate at the top of the pyramid, which is the higher functions cognitively that we need to be able to be successful at the bedside. So clearly, not only can I use simulation to standardize my evaluation across all the domains, it also gives me a way to assess the different aspects of each domain, and it's probably superior in its evaluation technique compared to other things. So I want to conclude my talk here and say that adult learning is complex. We have to address all the 3 domains, but remember that the challenges of all the 3 domains are very, very difficult. The challenges for the teacher is multi-pronged because of the various issues we talked about. Challenges for the trainee is very difficult because of the various issues we talked about. Simulation provides for a way. I'm not saying it is the only way. It is one more tool that can supplement the existing systems by standardizing the training. I've shown you some basic, simple things that we have done to teach various skills for trainees, evaluation, and probably give you feedback in a more objective way. Now, whoever gives feedback is going to use the same checklist. So the whole personality issue of the teacher is taken out when they give the feedback, and therefore it becomes more objective and standardized. And simulation provides for additional advantages. Training and evaluating all domains possible. I can do reflective learning by putting videos, which is the best way to modify the affective domain. Evaluation of higher cognitive domains, very clearly done. Archiving every interaction with trainee is possible for documentation, accreditation, and remuneration. Ultimately, if you're working in any of the Western universities, they're going to ask you, what is your productivity? If you're pretty much a teacher, there is nothing for you to show except that I've given so many lectures. Then there is no objective way for you to go to your department head and say, I spend so much time teaching our trainees, and this is a good way. I have so many files with date, clearly saying that on this date I have done 3 hours of training for so many people. Over a year I have trained 120 people in basic airway skills or ACS skills. Then I think there is an opportunity for you to professionally grow within your university, both financially and in terms of positions. Thank you very much.